Today I'm going to talk about oral estrogen versus transdermal. This is probably the top question I receive in the office when somebody has made that decision to pursue estrogen replacement therapy. I know on the back end, a lot of women are still scared to even entertain hormone replacement. However, what I want to do today is explain why estrogen, specifically oral estrogen, may want to be considered versus transdermal. And transdermal means on top of the skin, so any type of gels, creams, sprays, um, and also includes suppositories as well. And does the route really matter? So, key points for today is estradiol affects way more than hot flashes. When we talk about vasomotor symptoms, those are hot flashes. So, a lot of women, they'll go to their provider, they're having hot flashes. All right, estrogen's an option to treat for hot flashes, um, depending on who you go see. Others may recommend an SSRI or something else. Um, but in terms of hormone replacement, estrogen is that first thing. So what we're going to talk today is beyond hot flashes. Okay. So we know hormone replacement helps with that. It helps with a lot of the symptoms of menopause, but what else does it do? What else does it change in our physiology? And things that we will go over are lipids. We'll talk about insulin and insulin sensitivity. We'll talk about how it impacts inflammation, sex hormone binding globulin, how it affects our vascular system, and also the rest of our response to symptoms in general. Okay, so if you listen to most other influences out there, anyone that prescribes a lot of hormone replacement in the North American Menopause Society, a lot of them will favor transdermal estrogens because it bypasses the liver. And we're told that if it bypasses the liver, it must be safe, it must be better. But if you think about it, mostly all pharmaceuticals, or not all, but the majority, are oral, right? So you think about blood pressure medications, think about antidepressants, think about birth control pills, like all of those are oral. So we take pretty much oral medication for everything else. So why should estrogen, specifically bioidentical estradiol, be different? And why is bypassing the liver really requested? So we'll talk about that a little bit. And then on the other end, so the argument to this is oral estradiol may actually be better and it actually provides unique metabolic advantages. So we'll talk about that a little bit today as well. So when we're comparing oral estrogens to transdermal, we need to look at how they're delivered. So oral estrogens, they usually come in tablets, or if they're compounded, they can also come in capsules. Transdermal estrogens come in patches, they come in gels, they come in creams, and they can also come in sprays. And then I don't have this on here, but we also will talk about pellets, and pellets are still in that transdermal estrogen category. The absorption of these is completely different. So, oral, obviously, you have to swallow it. It goes into your stomach, it's absorbed through the GI system. So, if you have some kind of absorption issue, issues with ulcers, or if you've had gastric bypass surgery where you can't absorb as well, oral estrogen would not be a good choice because there's just that route of absorption is not there. Okay. Versus skin absorption. Um, if you have issues with your skin, so say you have bad plaque psoriasis or eczema or super sensitive or burn marks where you don't have any hair follicles and you're putting something on the skin to those areas, it's not going to be absorbed either. So it has to be the best circumstances. So this is often where we'll have that discussion in office, right? Do we have any of the issues going on that would sway us to choose oral versus transdermal? Now, the next big thing that we're going to talk about today is liver metabolism. When we take oral estrogen, we do have first pass metabolism through the liver. It goes into the liver first when it's getting broken down into the system, versus transdermal, it bypasses the liver initially, but eventually gets there by the end of the absorption. Okay. And this is where the scare comes in, or that, hey, if you take estrogen, it's going to go through your liver and this is a bad thing and it's going to kill you. So we should just avoid oral estrogen altogether. When we look at blood work and we check estrogen levels after somebody's been on oral estradiol or transdermal, it will impact systemic estradiol levels. So they both do have absorption into the bloodstream, where if we go to the lab to check estrogen, specifically estradiol levels, it is going to show up regardless of if it's oral or transdermal. So something to keep um, uh, remembering. The difference, however, might be in terms of vaginal estrogens. With those, we won't really see the systemic absorption unless you're on a significantly high dose. Okay. But the regular application, say on our arms, you'll get absorption with the transdermal that way. The major difference is, again, the liver exposure. So oral, we swallow it, goes through the GI tract, gets metabolized through the liver, and then it gets put out to our circulation. Transdermal, as well as pellets, they go on the skin, they get put through the circulation, and then later are metabolized by the liver. So that first pass metabolism or that liver effect is not necessarily harmful, and it may actually contribute to some of the metabolic effects that we have from estradiol, which we'll talk about next. The benefits of oral estradiol mainly is the cardiovascular protection. So the number one cause of death for women is cardiovascular disease, right? We're always scared about breast cancer, but really it's cardiovascular disease. Overall, we're more likely to die of a heart attack or stroke. So what can we do to protect our cardiovascular system when it comes to estrogen? In terms of oral estradiol, it does have an impact on our lipid profile. So it actually increases our HDL levels or our good cholesterol, and it reduces our LDL levels or the so-called bad cholesterol. It also increases our ApoA1 levels, and these are structural proteins that help create HDL in our system. So if we have that initial structure, we can make even more HDL to be cardioprotective. And then it also improves vascular function. So one of the ways it does that is it produces nitric oxide effects. And what we know about nitric oxide is it dilates the inner muscles of the blood vessels to widen them. And when the blood vessels get wider, it helps increase blood flow. It helps deliver oxygen to all our organs in our body. It helps deliver nutrients to our organs and muscles. And it helps also regulate blood pressure. So the one thing I can share with you about nitric oxide or an example is a garden hose. So if you use a garden hose and you turn on the water, you're going to have water coming out regularly. But if you put your thumb over the exit of the water and shrink down that the diameter of it, you're going to increase that pressure. So very similar to how blood pressure gets elevated in our system. If we take our thumb off, that pressure goes back to normal. So this is similar how nitric oxide works in our body. So it helps keep our thumb off of that hose to allow the blood to keep circulating nicely in our body and get those nutrients and oxygen to our system. Another thing that it does is increases sex hormone binding globulin. Sex hormone binding globulin is a protein that's made in the liver that binds to sex hormones in our blood. And these proteins will hold on to hormones. And depending on how much they hold on to it and transport these depends on how much hormone is active in our body. If it's too bound to that protein, it's going to hold on to it and we won't see the effects of it. But if it lets go of it, that's when we'll see more of the effects of hormones. Another thing that oral estradiol does is it helps with hepatic signaling. So it helps with cellular pathways in our body to help regulate blood sugar. This is often why when a woman hits menopause, all of a sudden their blood sugar levels start to go up, their insulin levels start to go up. They might become insulin resistant, or they might already be showing signs of type 2 diabetes with a hemoglobin A1C that is elevated. So one way to prevent this from happening is actually getting women on oral estradiol earlier, as soon as that, as close to that time of menopause as possible, to actually prevent us from becoming insulin resistant or diabetic. And this is, again, one of the reasons why we'll see women who've never had any blood sugar issues or issues with type 2 diabetes all of a sudden at the age of 50 or around the time of menopause show up with some kind of insulin resistance in office. The next is metabolic regulation in terms of how we process nutrients and as well as how we initiate tissue repair. So, if somebody that is chronically inflamed, this is where oral estradiol may actually be a benefit. So, it helps with that tissue repair, helps decrease inflammation, and same like anybody with any type of autoimmune disease that might be chronically inflamed, oral estradiol may help keep that at bay. In terms of sex hormone binding globulin and hormone binding, that protein that it has, again, it grabs the hormone and it holds on to it. So if it holds on to it too tightly and there's no free hormones going on in the body, then you're going to have symptoms, say, of menopause. And it also can create some of those unwanted side effects, such as like libido issues or acne or those lovely chin hairs, or excessive growth of hair, let's say, that we didn't have before the insulin resistance and the androgen excess. So the oral estradiol helps raise that sex hormone binding globulin, helps stabilize it. We can have too much and or too little, and this is why I find it's important to check levels, just to see where we're at and making sure it's not all protein bound and we still have some available for use in our body. Now, I'm going to go back to lipid effects again. So, using oral estradiol has different effects on the HDL, the LDL, and the triglycerides. So, oral estrogen will increase HDL levels, it will decrease LDL levels, but it can also increase triglycerides in some women. So, if anyone has any type of familial hypertriglyceridemia, this may be one reason to not use oral estrogen and to just use a topical. Transdermal is very neutral to triglycerides, so there's milder lipid changes overall. So if you're looking at, so say you do already have a lipid profile that's a little bit out of whack, oral estradiol might be the better option to go to as long as the triglycerides are okay. Going back to nitric oxide, we know again that it causes vasodilation, so helps dilate the blood vessels. It thus helps with vascular health in terms of the cardiovascular protection, so with the heart, and also prevention of strokes. And then also helps release the nitric oxide synthase in that the endothelium of the blood vessels. So by doing that, helps dilate the blood vessels, helps lower the blood pressure, again, helps get oxygen to the organs and the muscles throughout the body. So why is everyone using transdermal? Great question. So transdermal is considered almost forever safe. It's available in some places over the counter without a prescription, okay, at lower doses, because of that safety profile. It again doesn't go through the liver initially. So really in terms of blood clotting effect or triglyceride effect, it's not an issue. Okay. So for somebody that is very skeptical about hormones and are like, I am never taking this, I'd rather suffer or die, I get it. Okay. However, if you're looking for something, as a place to start, if you're highly symptomatic, where it's starting to affect you personally, it's affecting your relationship, it's affecting your kids, it's affecting your work, and you just can't function and you're really scared, this would be a good place to start. Okay. Um, However, if you're like gung ho and be like, okay, I'm just ready to start any type of hormone replacement, the oral estradiol would be a better way to go. Okay. So if you're very let's say, scared or apprehensive of, and have heard like everything bad about it, this would be the, if you're going to do a trial, probably the easier place to begin. In terms of the differences in terms of clinical reporting, the oral tends to improve mood more. It also helps with quality of sleep, helps better with the vasomotor symptoms, so those hot flashes and night sweats, and an overall sense of well-being. The transdermal, where this comes into play, is it works better with migraine prone patients. So a lot of women say if they start with migraines or headaches in their teen years, and it's usually hormonal and cyclical, we want to avoid oral estrogen in these women, and topical would be a better choice. The sensitive GI patients as well, like we talked about. So you've got the people that have already GI issues or upset stomach, chronic nausea, stuff like that, but also people that have had surgeries like gastric bypass. We want to, for them, we would go to the transdermal. And like I talked before, in terms of higher triglycerides, so if you have familial hypertriglyceridemia, where the triglycerides in the bloodstream are so high, we don't want to increase those even further. So for those patients, oral estradiol would be better. And then some people just are really sensitive to the adhesive. So the glues that you use to stick on the patches, or they're sensitive to the ingredients in the gels or creams, which can cause a dermatitis or burning of the skin. The whole purpose of is this to make us feel better, not worse. So if there's any type of issue with the adhesive or the ingredients in the creams or the gels, we might want to use oral instead of transdermal. Okay, and with all women, this is not cookie cutter. So the response is highly individualized, and I'll often change people back and forth, or we'll mix it up until they find what's best for them. The timing hypothesis is that estradiol appears more protective when it started earlier. So if somebody is still making estrogen and they literally go through menopause overnight and then their ovaries just stop making estradiol, putting them on oral estradiol, they're going to get way more bang for their buck than waiting 10 years or more to start something. Okay. Also, going near that menopause transition. So, same thing with starting earlier. The closer you are to menopause, starting estrogen, specifically oral, you're going to get better results, especially on the with the cardiovascular protection and things we talked about today, to help prevent those vascular diseases from forming, and then also help with the blood sugar and metabolism. Okay, so the timing of when you start this may actually matter more than the route alone. We're going to come back here now to personalized precision medicine. It comes down to the person. So for most, if you're looking at this, the oral, if you had no issues whatsoever, oral would be the way to start. But everyone is unique. So when we do that initial walkthrough of your health and family history, we're going to look at all these things. So the metabolic health. So if there's any issues with blood sugars, um, we're going to look at symptom profile. So if the symptoms are, off the charts, we're going to be a little bit more aggressive, let's say, in terms of hormone replacement and where we want to get to with levels and resolving those symptoms. We're also going to look at the lipids. So if somebody already has lipid issues and or their doctor is pushing statins, this would be a good place to start. Blood clotting history. So obviously if somebody has an active blood clot, we're not, we're going to avoid the oral to begin. We'll start with the topical. The insulin resistance, we would push more towards the oral. The migraine history will push more to the topical. And then patient preference, right? If you come in and you're like, I just want this, well, it's going to be really hard for me to convince you otherwise. And, unless one of these other things have come up, but obviously within your own safety. But if both were equivalent and literally it comes down to 50-50, it's going to come down to the patient preference. So key takeaways for today is both oral and transdermal estradiol. These are bioidentical, and it's only the bioidenticals of estradiol that we talked about today. The route, so whether it's oral or transdermal, it changes with it changes the physiology in the body. The oral estradiol creates meaningful hepatic signaling, so that first pass metabolism is actually what we want, versus the transdermal avoids it completely, which we may want in those certain circumstances that we talked about. Each may offer unique advantages, and individualization is absolutely essential. So I hope you learned something today. Keep showing up for yourself. Until next time, take care.